All right, thank you. Hey, I'm really grateful to be here today. I thank David for partly inviting me and Ewout as well. I want to say a little bit about me, just to give you context. I'm a chair of an academic department at the University of Washington. I actually run a data coordinating center, so I'm involved in randomized trials. I think about the methodology for diagnostic and then prognostic, and here today, predictive markers and how we can or can't migrate some of those tools from diagnostic to prognostic to predictive, and I'll say a bit about that today. And then lastly, I'm a licensed school teacher for mathematics, chemistry, and biology, so respectfully, I'm going to lean on all of those credentials today in this talk with you. I want to make three main points. I think that's the part I'll stop and emphasize in a couple minutes, 5 minutes and 10 minutes. All right, I want to skip an outline. That was there for me. Big green button is the pointer. The big red button, this green button. The big green button. Oh, that big green button. Thank you. I want to just start just to anchor things in context and talk about two simple examples. And each of the simple examples, I think, lead to basic collinearity between my talk and talks from the earlier session this morning. Here's an area where I start to collaborate in, which is in the area of depression, and then identifying kind of biologically based or imaging based phenotypes. Here's a paper out of a group at Weill Cornell, where they've taken fMRI data, done a whole bunch of behind the scenes analyses, and ultimately produced two scores, okay? Two scores that are supervised, were learned from the data. In fact, those two scores, then they say, may define subtypes of depression that transcend current boundaries and may be useful for identifying individuals who are most likely to benefit from targeted therapy. So one complementary example, but a common example, I think, to earlier examples this morning. Second one is this. This is got multiple elements to it, but this is around producing a genomic-based score. Again, I'm emphasizing scores here, where a genomic-based score has been validated. Actually, it was in fact a prognostic score, I believe, that actually had predictive power as well, so echoing things we heard about earlier today. This is actually what's produced as a report, information that's conveyed back. And I really want to talk about that element in my time with you. What can we say? What are the statements we can actually say from the data we collect and the analyses we produce? I really want to emphasize actually limitations in our ability to make specific statements. So leaning on this device, I'm going to come back to this 3 times. I think it's thematic for the whole session. We've talked a bit about data and inference at a population level. We've said we're really interested in focus at the individual level, so I picked that woman right there with a red and blue sweater as the person I'd like to be able to say something about from the data in hand. What I'll say as well is we often then go back and say we really can't do this, and I'll emphasize that as well. What we can do is say something about women like her, either a strata or a neighborhood. It's interesting, by design, I put this on an axis to identify that. It's a linear combination of a few different factors to find the women or the reference class, as was said earlier today, that I'll lean on to make statements for that particular individual. So I want to just give you a glimpse at some of the work that's been happening in statistics, and I want to emphasize the level at which this work is operating and the level at which it's concluding as well. So there's been a bunch of powerful work really emanating originally from Susan Murphy in 2011, where it talked about identifying rules, treatment programs, but then measuring the effect of that at the population level. Statisticians, not being so clever, called that the value as a target parameter. It's the population mean under targeted treatment. Since that, there's been a bunch of interest in really 2 paths that I'll identify here. One called Q-learning, which estimates the fundamental quantities of interest, what is the mean under both treatment and control. This simplifies it and says if you knew that, you'd recommend treatment simply based on whichever mean is better. And in fact, that rule would lead to a better value or a better population mean. There's another line of thinking that said, actually, we can directly estimate the treatment rule. We can skip that outcome model and directly make a prediction rule that optimizes the performance when you wrap it up to the population level. So I really want to say the focus here is on decisions at the individual level, but performance still back at the population level, right? So that's, I think, the first message that I really want to emphasize is this one, said in words that many contemporary methods consider action at the individual level, but still measure performance at the population level. I think it's appropriate, but there is a disconnect, okay? All right, so that's my first point. The second point I want to make is it's very difficult to migrate some of the tools that we've used traditionally for diagnostic and prognostic methods. And we heard actually this said at least twice today, and I'll just make it a little more formal. So we can ask for predictive markers or markers that could guide treatment. Can I talk about individual benefit? Can I talk about positive and negative predictive values or sensitivity and specificity? If I can, what are the assumptions I'm making? And then I'll talk a little bit about the value potentially of longitudinal data. So again, here the focus is on sort of using individual prediction classification metrics to characterize performance for markers or models that may be used to guide treatment. So I want to share this with you. This is actually done by many people. And I want to emphasize the communication element when we talk in this space. What do we mean when we say patients who benefit from treatment? Can you label those patients for me, the patients that will benefit from treatment? And the fundamental answer is no. Why? Because we'd need to see an untreated outcome and a treated outcome. So in a very simple space, you could envision an untreated outcome as positive or negative, and a treated outcome as positive or negative. I think what we're hoping to do is to identify this group, those who would benefit, where in fact we see their treated outcome would be better than their untreated outcome. But it's a fundamental problem that we can't measure that. Okay? This is called a principal strata. Statisticians have introduced this idea, Konstantin Frangakis and Don Rubin, more than a decade ago. It's interesting because Holly Janes, Margaret Pepe, Lisa McShane, Dan Sargent, and I wrote a paper and said, you can't do this, and published it in the JNCI. In that same journal, Rich Simon said, here's how you do this. So again, I think there's an important communication element about what we really can and can't migrate from diagnostic and prognostic measures. I'll show you why there's a fundamental problem of measurement here. And what is the data that we can see, and is the data that we can see adequate for this purpose? We can see data for untreated people, whether they get better or not, or whether they do well or not. We can see it for treated people as well. And from this, you collapse two of the groups together when you look at untreated data or treated data. So I really can't separate the folks who benefit with either particular data. I think sometimes we assume, actually, that we're in settings where maybe we can reduce this to a prediction problem sometimes, where we say, well, in fact, I think this is an audience where they're going to do poorly if I don't treat them. So in that case, really the critical data is, can the biomarker or measure identify treated subjects who do well, separated from those who do poorly. So in one setting, we can start to migrate tools for classification or prediction. These are two papers that talk about some of the standard ideas in that space. This may be some oncology settings where we think actually without treatment people will do poorly. In another setting, we may think, in fact, the treatment's actually pretty good. It's maybe expensive or rate limited in some other ways. Transplantation might be an arena where this is true. So in this setting, we can say what's the performance of the marker for the job at hand, which is really classifying or categorizing or separating people based on their untreated outcomes. Who's at most potential for benefit? Those with the greatest risk if left untreated. And excellent work, a plug for multiple people in the room, that kind of overlays or overviews all of the tools you can bring to bear if your problem looks like this. A couple other comments. One, we've tried to look, and others have talked about this as well. Well, you can't measure both conditions, but can you sometimes measure both conditions? Sometimes you can. So you can envision settings where you can do crossover data. If it's a quantitative measure, pain, function, maybe you can measure that individual in both conditions. So in this setting, you can actually at one time and another time change the condition and start to try to learn who are those people who have what appears to be a better outcome treated than an outcome under control. It doesn't solve the problem purely. These graphs are from a paper we published that still talk about there's still identifiability problems in this space. It's not gone away. It also invites other questions like, is that really the goal, whether my one outcome is better than my other one outcome, or is it really my mean outcome? Or like repeatedly treating me one way and repeatedly treating me another way. What is the target parameter or question here? All right, so I want to say from this one, this would be my second main point. I think attempts to define, quote, patients who benefit, that needs to be clear. And I think it can lead to an outcome-based definition that's just not measurable. So a fundamental problem about talking about the performance of classifiers for who should get treated. So really sort of living at this individual level is a challenge, I think. All right, last comment. Really the third point I want to make is around the score idea. There's actually a couple important things I want to say on this slide. We've looked at methods. There's a paper I highlight on the bottom that really talks about trying to calculate the score that we've mentioned, which is really the difference between the treated mean, treated risk, and the untreated risk. That's the benefit. That's for given characteristics, what's the difference if I'm treated as compared to if I'm not treated. It's interesting. I want to just comment that we've heard this stated. That's an important score. Maybe we call it the predictive score. It lives together with the prognostic score, right? What's your untreated expectation? So I just want to call out, we've heard from talks in the morning, the importance of looking at this part of the score, but I think the fundamental goal is to try and learn that predictive score, the benefit that would be assigned to a given patient. So I want to push us to say, yeah, it's important to look at baseline untreated prognostic risk, but let's at least start to try to get scores that measure the ensemble aggregate expected benefit. I want to say what we can tell people is really at the level of the score. So I want to say, can we do validation about statements for that woman in that red and blue sweater? Fundamentally, no. It's too small of a group. What we have to do is to find an appropriate anchor for that individual. And these are the metrics, I think, that identify appropriate metrics. What's the benefit or what's the risk? So just to emphasize, I think, that fundamental point, I'll show you this. I'd love to be able to validate statements about individuals with multiple characteristics. How would I do that? I'd find other people with those characteristics. But what I do is measure outcomes and then summarize locally. But if I want to find 10% of the people, no problem. With one variable, I can find a 10% window around that score. If I need to find 10% based on two scores, each axis needs to be 32% wide, so the intersection is now 10%. So a much bigger neighborhood, much less local of a statement. You can see as you push the number of variables that you'd like to anchor on higher and higher, you're really covering the entire space. With 5 variables, you're going 2/3 of the way on each parameter to talk about that woman with that red and blue sweater. So fundamentally, this is a challenge. This is almost impossible to do unless the markers are low dimensional and discrete or summarized in a score. So that's I guess, the purpose of this slide, is really to return and say, what we can do in validation is make statements about people with a given score, whether that's fine or coarse. I'm really envisioning it as a quantitative score, in part because Frank will criticize categorization of that score. I think we have the tools to look at it as a quantitative score. I want to say what's in this graph is a cartoon picture of patient outcomes under no treatment and under treatment, right? That's sort of the fundamental thing we can look at. The score here, the benefit score, is the difference between these. 40 is the difference between treated and untreated. Minus 40 is the difference between treated and untreated, shifting the focus to a slightly different score. We can do local non-parametric validation here. We have to emphasize separate development and evaluation data, and I think separate development and evaluation assumptions. I'm happy enough to generate a score by adding together, quite simply, multiple markers. I let that assumption go when I move to validation and look at that generated measure and its relationship to outcome. So separating those two particular goals. I want to say in the last 16 seconds that I have, this is the idea between local calibration. I can look locally at values defined as a neighborhood, and then talk about the mean outcomes in two conditions. It's quite similar to what was done in that oncotype DX graph. It's on the right. The slight difference here is this is a risk score and this is a benefit score for these two settings. All right, so I think that's my third main point. I really wanted to say methods should consider development of action at the individual level, but that action's based on a score, and the score can be validated not necessarily at the population level. We could validate it there as well, but we can validate it locally. We can validate whether that score is giving an accurate representation of the expected benefit of being treated as compared to not treated. So be clear about performance claims. Individual classification's hard. Multidimensional markers we can collapse. These are all intermediate steps to decision making. Anirban said something around that earlier. I think that's important. And I'm really trying to emphasize today the need to be careful and clear about what we can say in a given setting. And that's my hometown. Thank you.